Hello, everyone. Thanks so much for joining us for today's episode of CHS Presents Health Connect. I'm Jane Hansen, along with my co-host, Dr. Patrick M. O'Shaughnessy, Catholic Health Services Senior Vice President of Medical Affairs and Chief Medical Officer. Should you find yourself or a family member facing a serious illness, the care you seek may encompass a lot more than medical attention. For both caregivers and the patient, it's important to effectively manage all symptoms of pain, focusing on the quality of life. The amount of support necessary after such a diagnosis may go beyond what one's family is able to offer, and a palliative care program can provide this assistance at any stage of the disease, whether it is terminal or whether it's chronic. And I think that's a really big point to make here, Dr. O, is about what is the difference between palliative care and, say, hospice care? People get that really confused.
Right, and I'm so glad that you mentioned chronic care disease management and not just terminal disease management, because palliative care really is an integrated add to many disease processes, and we're very fortunate at CHS to have such a progressive and excellent integrated network of palliative care providers that can provide those services to their patients and families. And it's one part of the overall management of a disease process, whether it be helping a patient's family through a chemotherapy regimen, helping a patient perhaps stay out of the hospital with pretty advanced congestive heart failure as an example, or if someone does unfortunately have a terminal illness, really providing a better state of not just physical but spiritual and emotional wellness, and to ease pain and suffering, and to help in terms of a transition to hospice to provide a more comfortable environment. But many times when people hear palliative care, they just focus in on terminal illness, and it is so much more than that.
Right, I mean, because that's the first thing that came to my mind, and I've always wanted to understand what the difference is. So has that definition changed, do you think, at all, or has it always been the same? We just now have enlarged upon it.
Well, it has, and I think that's part of, and as you meet Doctors Page and Calvess, you'll see how their approach to providing palliative care services really embodies the true new definition of these services, which is really to be providing integrated care as part of the other care delivery teams and helping patients and their families cope with what they're facing.
Is it always in hospital? Is the patient in hospital, or the patient at home, or what is it?
It could be all of the above, and I think one of CHS's strong advantages is we actually are one of the only healthcare systems to have a fully ambulatory outpatient palliative care center. And this is, again, right by Good Samaritan Hospital, but again, in an outpatient environment. These services are also provided in an inpatient or hospital environment, or it could also be extended into the home.
So when you think about this kind of care overall, I know we've talked a lot about the various things that are involved in CHS and about helping patients live better lives, not just longer lives, but even better lives. So how does somebody find out when this is what they should be doing? How do you learn about that?
Well, I'm glad you brought that up, because part of what we're trying to do, again, with physician leaders like Doctors Page and Calvess, are to educate the medical providers on these services. A few years back, New York State passed a law called the New York State Palliative Care Act, which really looked at earlier use of palliative care services for chronic disease management, helping folks to stay healthier, and again, in a more integrated setting. But many providers did not know when to start having these conversations and when they should be saying to families and patients, I think that you'd get better benefit, not just providing the curative pathway and things that we're doing now, but let's add in some palliative services. And in fact, even CMS, the Centers for Medicare and Medicaid Services, has realized this, and they've launched what's called the Care Choices program, and our division won a grant for that.
Oh, really?
Yeah, and it's really a wonderful thing, because what it does now is it allows funding for patients to receive continued curative pathway interventions, and in parallel, add in the palliative care services. So again, it's not all or none. It's really integrating it together.
And of course, we're going to continue to discuss how this has helped so many people who are seriously ill and their families in our community and beyond. We'll speak with Dr. Carrie Ann Page, the Chief Medical Officer of Hospice and Palliative Care Services, and Dr. Pedro Calvess, the Senior Associate Medical Director for Palliative Care, both from Catholic Health Services. Stay tuned. We'll be right back with today's episode of CHS Presents Health Connect. Hello, everyone, and welcome back to CHS Presents Health Connect. Palliative care is an evolving healthcare specialty focused on support systems and pain and system management for those with serious chronic illnesses.
Joining us today to discuss more about this quality of life care is Dr. Carrie Ann Page, the Chief Medical Officer of Hospice and Palliative Care Services for Catholic Health Services. Welcome, Dr. Page.
Thank you very much. It's a pleasure to be here.
So your title actually is a new one. You started about 4 years ago in Catholic Health Services, and it's just because of the title is demonstrative of how this has grown.
Yes, it is. So palliative care is a field that is relatively new in the spectrum of medical specialties over the last 10 to 15 years, and is a growing field as there's more and more recognition that patients with serious and complex illnesses have symptom needs and psychosocial and emotional, spiritual needs that require additional layers of support and expertise for the most successful management for patients and their families.
And what we're talking about here, again, I know we've already discussed this earlier, but that concept that this is not about treating patients who necessarily have a terminal illness. It's about treating patients who have a very chronic and acutely chronic illness?
That's correct. So we typically use the term serious illness, which describes an illness that has the potential to limit life expectancy, but is an illness that that a patient may live with for many years, right, and may affect their ability to function and the quality of their life, right. And while we treat that underlying illness, and it's very important to continue to treat that underlying illness, it's also equally as important that we pay attention to the effects that that illness has in terms of the symptoms and the impact it has on people's ability to function on a day-to-day basis.
So give me an example. What kind of a chronic illness might be a patient?
So something like congestive heart failure, which is a disease that people may live with for many years, right, but may impact their function, their ability to exercise, their ability to work, their ability to manage on a day-to-day basis over a long period of time.
Is this really costly?
In terms of chronic disease, is costly to the patient, it's costly to healthcare, and I think part of what the program has been able to do is to get these folks as well as they can possibly be, and many times help keep them out of the hospital and keep them home with their families. And again, it goes back to what I said earlier, the right care in the right setting at the right time in the right place. But as you'll hear from Dr. Page, it's really about providing integrative care.
Mm-hmm. So who's there? Describe to me all the people involved.
So palliative care is provided by a team of professionals, physicians, nurses, social workers, chaplains, and many other specialties who work with a patient's primary medical care team, which may be their primary care provider and the specialist taking care of their underlying illness. The palliative care team works in concert with the other medical providers to make sure that all symptoms are addressed and to provide an extra layer of support to both the patient and the family. Because the underlying goal of providing palliative care services is to enhance a patient's quality of life and to make sure that their treatment matches the things that are important to them, that it matches their goals and matches their values.
So does that mean this team gets together and they have meetings and say, let's figure out, you're going to do this, I'm going to do this, here's how much they need of this? I mean, how do you manage that?
So there's a lot of communication. Communication is a cornerstone of the practice of palliative medicine. Communication with the patient and the physicians, communication amongst team members. Sometimes there are meetings when people sit down and talk about the patient and the issues that are going on for that patient to solve their problems and to help manage their problems. And other times the patient may interact with different members of the teams at different points in time.
Is the doctor, the primary caregiver, always the person in charge?
Well, the palliative care team is usually headed by a physician with specialized training in hospice and palliative medicine, which is a subspecialty of medicine. But that physician and the team always work in concert with the patient's primary provider, medical provider.
And how much do you like to see the family get involved?
Oh, it's so important. Really having patient-centered care and having an engaged family makes all the difference.
And families are involved. Sometimes we don't recognize how involved families are.
Sure.
And sometimes we underestimate the impact that the illness that the patient has on the rest of the family. And then we wonder sometimes why things aren't perhaps moving in the direction we want, because we fail to support the family to be able to support the patient.
So who's appropriate for this, and how does somebody know that they're either eligible for it or that that's the best treatment for it?
We identify patients based on their need. So we look at patients who have, as I said, a serious illness, something like a cancer or congestive heart failure or chronic pulmonary diseases or a form of dementia. And then we look at what their needs are. Do they have symptoms such as pain, shortness of breath, problems with anxiety or depression, or problems eating, weight loss, nausea? We look at whether or not they need emotional support or help with decision-making around treatments and understanding the course of their illness. And we look at whether or not they have a lot of contact with the healthcare system. Is this somebody who's struggling and who's been in and out of the hospital, right? And we need to do a better job helping get control of their symptoms so that we can avoid those unwanted trips to the emergency department.
It sounds like it could be a real relief for somebody who may not be aware that this is even offered. And I'm sure there's a lot of people that don't know about it.
You're right, there are. And so our goal in doing programs like this is to help spread the word and to let people know that palliative care services are available both in the hospital setting and in the community.
You talked about the Palliative Care Act, I believe you called it, that was passed by New York State. Did that mean that then insurance monies would be able to pay for this or not?
Well, what it really did was it opened the eyes of so many in healthcare to say, you need to start thinking about these types of integrative services for other disease processes, whether it be congestive heart failure, chronic pulmonary disease, chronic kidney disease, because we know that by earlier involvement of palliative care, outcomes are is best optimized or improved.
Now, can you talk to me about what patients or their families might say to you when they've gone through this process? What's the kind of reaction you get from them? And anecdotally, I'm just wondering how they feel about it.
So most patients are incredibly grateful, right, because they have time to sit down with members of the medical team, hear their concerns addressed, and spend time figuring out what's important to them. Patients are grateful for the extra attention to symptoms they might have that improve their physical well-being, as well as the ability to kind of regain control sometimes over the disease they have, right? To understand it better, to make sure that the choices they make are fully informed ones, and that the choices match the things that are important to them.
That word you just used, they feel like they have some control, because I'm sure most people
Absolutely.
in a chronic disease don't ever feel that way. So how important is that to you as this caregiver?
It is so important, and I think it gets back to, again, what I see our palliative care leaders and teams doing. I call them the great integrators. They really are breaking down silos, pulling everybody together, and involving the patients and their families in these processes, which gives them back a sense of control over many times, which is a devastating illness.
I know I keep asking you this, but how important a role has technology played in being able to do this, and at least managing schedules?
It certainly is important, right? And it helps the communication issues between both different members of the team as well as with patients and families.
And so patients are incredibly grateful for all this. And what about family members? Do they feel like they've been given at least more information, or maybe not left in the dark, or maybe they even feel like they have more control?
Absolutely, right? Because they have multiple members of the team to reach out to for their own support, as well as to improve their understanding of the patient's medical condition and what things they should be doing for the patient.
How often are they at home versus in this care center that you have or in the hospital?
Well, so most patients actually are at home. It's said that 80% of all people with a serious illness are living in the community, that really only a minority of people are in the hospital or in a nursing facility at any one time. So most everybody's living at home.
That's great. And you're available 24/7, 365?
Our physician practice has ongoing availability, yes.
All right. And I'm sure that this has given you a lot of things to be grateful for, too, as a physician.
It is. It's tremendously gratifying to be able to help people who are vulnerable because they have a serious illness be able to achieve good control of their symptoms and feel like they're supported in their healthcare journey.
Thank you so much for being with us, Dr. Pedro.
You're welcome.
We really appreciate it. We're going to take a quick break, but our discussion will continue right after this. Welcome back to CHS Presents Health Connect. Palliative care is not limited to the terminally ill or the dying. The goal is to focus on symptom management and improve quality of life, and also to offer hope to patients who suffer emotionally, physically, or spiritually due to chronic, catastrophic, or terminal illnesses.
Joining us now is Dr. Pedro Calvess, the Senior Associate Medical Director for Palliative Care for Catholic Health Services. Welcome, Dr. Calvess.
Thank you very much.
Good to have you here.
Thank you.
Now, I asked you earlier about this whole concept of why you're involved in palliative care. What does it bring to you?
Well, it brings me great satisfaction. I began life as an internist. I began treating adult internal medicine. I did critical care medicine, which is medicine in the ICU. And what I found was, over the course of the years practicing that, is that I couldn't always cure everybody. But I did find that over the course of the years, I could always make them feel better. And that has led me to extend the idea of taking care of people's symptoms and bringing it into their emotional and their physical and their spiritual well-being as well.
When we've thought about palliative care in the past, many people say, oh, that's either a step to hospice or it's a choice between palliative care and hospice. And I really want to get this point to people watching, that it's about managing a chronic disease more than it is preparing somebody for death.
Right. It's not preparing somebody for death. Palliative care is when you have a disease that is life-altering, a disease in which you may have a change in your lifestyle, a disease that could potentially become something that could turn into something fatal. And there are many diseases like that nowadays. Thank goodness medical technology has gotten to the point where a lot of diseases that used to be universally fatal are now chronic diseases. So what palliative care does is we come in and we give you options. We let you know what can and cannot be done. We translate it into easily recognizable words, because sometimes doctors use very big words. And we make it so that you have control, you have the options, and not just you as a patient, but your family.
And why is it important for CHS to really go down this road, Dr. O?
Well, I'll tell you, again, more and more people are living longer. More and more of Americans and Long Islanders are suffering and developing chronic disease. So when you put that together, the proportion of patients that we care for with serious or chronic diseases is growing. And so palliative care provides that extended service platform for those patients as part of the integrated care delivery system.
Yeah, which again is relatively new overall, this whole integrated system, but it's really providing a lot better service for people out there. So what are the symptoms? I mean, people might be watching saying, I don't know if I'm eligible for that. What are the symptoms that they should call you about?
Well, let's say you have somebody who has mild, as Dr. O said before, congestive heart failure. A congestive heart failure can happen after somebody had a heart attack, or congestive heart failure can happen if somebody has prolonged high blood pressure over the course of many years. And what people will notice is that they'll start getting shortness of breath. Instead of being able to walk a block, they'll be able to walk half a block. Instead of being able to walk one flight of stairs up without a problem, it becomes 1 or 2 steps. This progressive shortness of breath is something that their cardiologists or their primary doctors would take care of. But also we would come in and say, how is this affecting you? How is this affecting your lifestyle? And we would come up with some medical fixes, and we would also come up with some psychological changes that you might want to make in your lifestyle, as well as maybe some physical changes. Maybe you can move your living room to the first floor instead of the second floor. All those kind of things. We'll think outside the box to make your symptoms better.
And unlike other places that offer palliative care, there's a spiritual component to all of this as well.
Yes.
Can you describe that for me?
Well, part of our approach is to deal not just with the physical or the emotional, which all palliative care programs have. CHS is unique, I believe, in that we place an emphasis on the spiritual from a Catholic point of view, as well as a complete point of view, that a person is a whole person, and what makes up a whole person is their spiritual aspect, what their belief in God is, and what their hopes for the future are.
But that does, you don't have to be Catholic to do it, to participate, though.
Not at all, no. We have many patients who have a whole gamut of different religions and spiritual beliefs who benefit from the fact that we're not just thinking about the here and now.
And then when you talk about the psychological aspects of it, is there depression? Are there all those sorts of things enter into it?
No, 100%, Jane. When you look at when someone and their family has to deal with one of these diagnoses, if Dr. Calvess was mentioning, it could be devastating. And as your quality of life changes, it then spurs on added symptoms of depression. You're not able to do the same things you were to do before. And that could really not only affect you emotionally, but actually can further deteriorate the physical symptoms that you're having and lead to further complications of care. So again, that whole integrative approach in treating the whole patient and the whole family as a whole is, I think, what sets this program apart.
Okay, so somebody is watching this and says, you know, I'm interested. This might be exactly what my father or my sister or somebody needs. What do they do there? Do they have to go to their doctor, and is there a whole process?
Well, if let's say you're in the hospital, usually what happens then is you ask your doctor to get a palliative care consultation. In the community, as Dr. O said before, we have an outpatient center. You can ask to come to our center, either from your doctor or yourself. This is one of the unique situations in which you can initiate a consultation. You as a patient or a family can initiate a consultation of a specialist without getting a referral from your primary
And
doctor.
how do you do that? They can just call you guys?
Yes, we have a number, and I can give it to you now. It is 631-828-7417.
Okay.
And that is our palliative care hotline, so to speak, and that is where people call to get onto the palliative care service.
And I'm fairly certain that the message you'd really like to get across here is, if you've got a chronic disease and you need our help, come, call us. I mean, the worst thing that can happen is you can say, you know what, you're too healthy.
Right. Again, it's putting control in the patient. And as Dr. Calvess mentioned, this does not have to be something that's initiated by a physician. We do want physicians to understand the scope of services and what could be offered by the program. But again, if you and a family member are going through this, you need to know that these services are out there. And you need to know, in the context of what we've discussed during the show, really what it encompasses around palliating the symptoms.
What does palliating the symptoms mean?
So everything as Dr. Page and Dr. Calvess spoke to, it's really about alleviating the symptoms of either the chronic or a terminal condition to make you feel better, to try to integrate that in both, if it's possible, for a curative pathway along in parallel, or when not, as Dr. Calvess mentioned, it's to relieve the symptoms that are really degrading the patient's quality of life.
And by engaging in this, it doesn't mean that you're giving up on becoming healthy again.
Absolutely not. What this says to you is that not only can you get better, but you can feel better.
And that for you,
That's it.
that's it. Makes it rewarding for your job.
Absolutely.
All right. Thank you so much for being with us. We really appreciate it.
Thank you very much.
Thank you.
Thank you.
This whole concept of the palliative care sounds so wonderful for people who are suffering from some kind of a chronic illness, etc. But we talked about depression, but I'm also thinking about how they're probably so stretched monetarily. Their budgets are very slim, and now you're offering this whole consortium of care. But is there a big financial price tag attached?
No, there's not. The majority of these services are covered just as if you would see any other physician. The program itself, as part of being part of CHS, and we are mission-driven, we do subsidize the program to make sure not only that it is available, but that it continues to grow, so that some of the services that we may have in some of our campuses to a higher degree, we're now expanding that across the CHS network to other facilities as well, so that all the patients would have access to this care.
Dr. Page, I know, said she'd been at CHS for roughly around 4 or 5 years, something like that. And that was a new position that you created. So I'm assuming that you've seen tremendous growth in this area.
We have. We've seen growth, and I think as greater acceptance both by patient and family and primary caregiver, it's led to more frequent consultation. more effective integration of care, which has led to better outcomes for patients. Because again, so much of this involves treating the whole patient. And again, I look at them as great integrators. This team and the leadership especially has done a wonderful job integrating care, because you can imagine some of these folks may have 5 or 6 different doctors and care teams. So not only are they doing their component, but they're also doing, if you will, some quarterbacking, pulling all the pieces together, forming an integrated care plan that the patient or family both would like to see further developed.
So quarterbacking, I mean, I love how you always put this in these terms that are so easy for people to understand, but it's got to be relief too.
It is.
To say I can go someplace, I can get all this help, and every day I don't have to think, how are we going to do this?
It is. And it's, even to some of the more common things, as Dr. Calvess was saying, in terms of, well, what's your living situation like? Is it hard for you to get up the stairs? You can't do it. Can we talk about how we could rearrange things for you so that it's not that big of a challenge for you? And getting you back to normalcy as best as possible, if that makes sense. So, folks are dealing with so much when they go through these episodes of care that if their world can become a little bit less painful, a little bit simpler, it makes a whole big difference for them.
And you've got, if somebody does call for a consultation, because we've urged them to do that if they're interested, what will they find there?
I think what they would find is a complete comprehensive program. So as an example, if they were to go into the ambulatory center that Dr. Calvez had mentioned, they'd see an integrated approach with a physician, with a nurse, with a social worker, and a complete look at the full picture and what they can do to integrate that care.
And that full picture, I bet that makes you proud.
It does. We're very blessed. We've got some wonderful providers that are passionate about what they do, and I think that showed today.
Thanks. And that's all the time we have for today.
For more information, you can visit www.chsli.org or call 1-855-CHS-4500 for information about any of the Catholic Health Services of Long Island facilities.
Thanks again for joining us. We hope to see you next time on CHS Presents Health Connect.